we have considerable concern is the rapid spread of a procedure called preimplantation genetic screening. Preimplantation genetic screening, or PGS, is the medical term for evaluating whether an embryo is chromosomally normal before that embryo is transferred into the uterus. Once again, this is a concept that on first glance appears logical, makes all the sense in the world, but unfortunately in medical practice has never proven to work. The idea, the concept is that since in humans many embryos are chromosomally abnormal, and since the majority of chromosomally abnormal embryos don't implant, therefore don't lead to pregnancy, if we a priori, before transfer, can select out chromosomally abnormal embryos, we should end up with chromosomally normal embryos and therefore better implantation, better pregnancy rates. This concept first arose about 10, 11, 12 years ago. And in those days, we biopsied the embryos to determine the chromosomal makeup of each embryo on day 3, when the embryo had 6 to 8 cells. And like again now, in those days, the procedure swept the world. Thousands and thousands, if not hundreds of thousands of patients underwent this procedure at very significant additional cost. We tried to warn them against it, but nobody listened. And then colleagues from Sweden published a paper in the New England Journal of Medicine, a prospectively randomized study, where they demonstrated that indeed, at least in older patients, the procedure actually reduced pregnancy chances. And the procedure quickly fell out of practice. Indeed, SRM, European Society for Reproductive Medicine, all came out with public opinion statements that the procedure does not work. And the use dropped. And now, 2 or 3 years ago, a new wave, a new form of PGS was introduced, which is claimed to be technically superior. And these claims are correct, because we have new technologies where we can test the embryos with greater reliability for chromosomal abnormalities. But these new techniques also mostly require that the biopsy of the embryo be moved from day 3 to day 5. And we just discussed the disadvantages of blastocyst stage transfer. And I just mentioned that only roughly 20% of patients statistically benefit from blastocyst stage culture. Now, to do PGS, this new PGS, patients have to be cultured automatically to blastocyst stage day 5 or 6. And only then are the biopsies done. And so automatically they have all the advantages and disadvantages of a blastocyst stage transfer. Plus, with the blastocyst stage transfer representing a method of embryo selection, they now have 2 consecutive methods of embryo selection. And what that means is that only good prognosis patients in the first place benefit from blastocyst stage transfer. Now, only those patients who have embryos that make it to blastocyst stage undergo biopsy. And once again, there will be some patients who will have made it to blastocyst stage transfer with a small number of embryos, and suddenly all of the embryos will be found to be all chromosomally abnormal. And so we have yet a second stage of selection of only good prognosis patients. And so what this means in the end, that like the concept of blastocyst stage culture to day 5, PGS is a good method of selecting best embryos, healthiest embryos out, but it is only a good method, once again, for the good prognosis patients. And that is the young woman with lots of embryos. Well, those are the women who, even if I transfer them on day 3, without culturing them to day 5, without PGS, have already the highest pregnancy chances. Now granted, maybe adding blastocyst stage culture and adding PGS will give me a few extra pregnancy points, granted. But is it worth that additional money to get a patient who already has the highest pregnancy chances into a slightly even higher level? Nobody has answered the question, and we seriously doubt it. But this is yet another method that is spreading like wildfire, is being applied to everybody, when in fact only a tiny minority of patients statistically will benefit, while others will actually reduce their pregnancy chances, and on top of it add about $3,000 or $4,000 to the cost of the IVF cycle. So we here at CHR are very skeptical in utilizing this, and would argue that patients discuss this with their physicians very, very carefully and make sure that they are in the group of patients that may benefit from any of these procedures.